Hello, my name is Benjamin and welcome to Med One Pager, where I try to get a topic in medicine and summarize it on a single page to create this kind of one chart you can look at or read for recall, for quick reference, and everything like that. But it is important to note that this cannot be used as a direct tool or as a guideline for patient management, and thorough medical training cannot be obviously cannot be replaced by this. So today I want to talk about heart murmurs. And heart murmurs are basically abnormal sounds heard when you auscultate the heart with a stethoscope. So we have the first and the second heart sounds, but we also have the third and fourth heart sounds also somewhere. And when it comes to distinguishing the normal from the abnormal, we would like to understand where does this all come from, instead of trying to cram that this is a systolic murmur, this is not a systolic murmur, it's a diastolic murmur. This is what I like to understand how these murmurs come about, and either way, I don't think then I can forget or you can forget how the murmurs are going to come about. So when you look at the first heart sound, the S1, which you're going to hear as the lab, because we know the heart sounds produce the lab dab sound. So when you look at the lab, it is the S1 heart sound, and it's going to be produced by the closing of the mitral and tricuspid valves. And this is going to happen at the beginning of systole. So as the ventricles begin to contract, these valves are going to close, so blood does not flow back to the arteries. So when these valves close, we hear the lab sound or the S1 or the first heart sound. Then the second heart sound is going to be produced by the closing of the pulmonary and the aortic valves, which is going to happen at the end of systole. So when the ventricles are beginning to contract, we hear the first heart sound, and when the ventricles are finished contracting, we hear the second heart sound. Then the third and fourth heart sounds may not be heard sometimes, and they are going to be very low and not easy to pick up. And some people will actually say to pick it up, you have to use the bell. You have to use the bell instead of the diaphragm of the stethoscope. So the third heart sound is going to be produced by the sudden deceleration of blood entering the ventricle walls. This is going to cause vibration of the walls. So as blood enters the ventricle, it is going to enter the ventricle, and at one point it's going to stop. So that stopping there is going to have the recoil of the ventricle is going to cause some vibration, and that is what you pick up at the S3 heart sound. And that shows you that this is going to happen before actually systole begins. So the S3 is going to be heard before the S1. Then when we go to the fourth heart sound, this one is going to be due to ventricular vibration due to a force for atria. So as the ventricle, so let's say we have a ventricle that has been hypertrophied and it is stiff. The atria is going to try and push it into that ventricle. So the atria is going to become strong, it's going to become furious, and it will push with a lot of force. And this will end up producing a fourth heart sound, which we hear the S4. So this can be pathological in some cases, as well as it can be physiological, more so in young children. But if you had this in someone who is old, it is very important that you consider that there is an underlying pathology there. So what causes heart murmurs? When you look at heart murmurs, they're going to be majorly caused by a change in the flow of the blood within along as it passes the various points of the heart, mostly as it passes the valves. The flow is supposed to always be what we call a laminar flow, whereby the fluid layers are moving parallel to each other. It is an organized flow. But when we have something in the way, it is going to cause turbulence. It's going to disorganize that motion. And that is how we end up with a heart murmur. So the turbulent flow is going to be chaotic, irregular, and it is what you will pick up as another sound. But sometimes it may be just the valves themselves. Maybe there's this valve that is flipping over, and it will cause still at the end of the day, it will be turbulence of the blood, and it will cause a sound. So when you look at the pathological and physiological murmurs are going to be always excessively heard within the systolic phase. So between the lab and dab, that's when we expect to hear a physiological murmur, and they may be due to just hyperdynamic states like someone who is pregnant or someone with anemia or someone with hyperthyroidism. They're going to have a lot of blood moving, and we may pick them up because of this increased flow. For example, if you are at the river, the place where the water flows the highest will have a higher intensity. So it's the same thing here. We are somewhere in the body, we are having a state whereby there is a very increased demand. So the blood will always be whooshing. You will always hear it, even if everything is actually normal in that heart. Then when we look at the systolic murmurs, so we think to look at the systolic murmurs is the systolic murmurs occur between the S1 and S2 sound, and they can be early, they can be pansystolic, and they can be late systolic. So the pansystolic are the ones that are going to be there throughout the whole phase of contraction of the ventricles, and we're going to see why. So when you look at the early systolic, for them they're going to be caused by a ventricular outflow obstruction. Think about a pulmonary stenosis whereby the pulmonary valve is stenosed, it is stiff, it is not opening fully. It is creating an obstruction to the flow of blood. In that case, as systole begins, the heart is beginning, the murmur is going to begin immediately. It's going to begin immediately. And as the blood forces that valve open, as it forces its way through that valve, that murmur is going to start going down. Because as well, even the pressure of the blood inside the ventricles is going to be going down. So at first, we're going to push with a very high force. And as that force pushes the blood, the murmur is going to begin immediately because of that very, very high pressure. And as the pressure goes down, the murmur is going to also go down. And this one produces the classic, what we call the crescendo, decrescendo. So when you look at a pansystolic murmur is going to be it's going to have the same rate, the same intensity throughout the whole systole, the S1 and S2. So, and it's going to be caused by the valves communicating with the atria. So whenever those valves have a problem, and maybe they are not sufficient, they are not closing well enough, they are not sealing off well enough during the systole, blood is going to continuously going to trip back into the atria. And that is going to produce a pansystolic murmur. It will begin immediately as the ventricles contract, and it will not stop until the ventricles finish contracting. But it's going to have an intensity that is characteristic. It's going to be fixed. It's going to be constant throughout the whole systolic contraction. When you look at the late systolic murmurs are going to occur because we have maybe a place, for example, in mitral valve prolapse. Look at the valve, it's there, it is closing very well. But as blood continues, the valve prolapses, the valve folds the other way around because of the pressure. So the valve is going to at first hold, but as the pressure builds, as systole continues, pressure is building within the ventricle, these valves are going to flip over, they're going to let go, they're going to give up, and then we shall have that late systolic murmur. The same thing is going to happen in hypertrophic obstructive cardiomyopathy, because imagine a part of the heart is asymmetrically enlarged somewhere up there, as blood leaves the ventricle, probably is hypertrophied. So this hypertrophy is going to cause a narrowing in that part where the blood is supposed to pass. So at first, contraction begins, the pressure is going to be high and the obstruction is going to be relieved. But as the pressure drops, the obstruction is going to come back. The hypertrophied part is going to narrow the lumen, and that is going to produce our turbulent flow, which will eventually cause the murmur. So that is with systolic murmurs. And when we look at diastolic murmurs are going to be early, and we have the mid-diastolic. And these are going to be due to aortic and pulmonary regurgitation. And it's easy when you think about it. During the diastole, when the ventricles are filling, those pulmonary and aortic are supposed to be closed, so blood does not trip back from the pulmonary artery and the aorta, tripping back into the atria or the ventricle. actually to the ventricle. So if those valves are regurgitating, they're letting blood trick through during the diastole as the heart is filling. It's going to produce that diastolic murmur. It's not going to happen during systole simply because during systole the ventricles are pushing and the pressure down is much. So blood can't move into the ventricles down. But as the pressure falls during diastole, the blood is going to trip backwards and then we shall end up with that diastolic murmur. Then you have a mid, and that is going to be an early diastolic murmur. So we have the mid-diastolic murmurs, and these ones are going to be caused by mitral and tricuspid stenosis. And this is going to begin when, as blood is coming in to the ventricles from the atria, it's going to pass through these narrow valves. But at first, the pressure is going to be less, so the blood may pass through without much problems. But towards the end, because the blood is trickling through slowly and blood is accumulating in the atria may contract. The atria may try to give it a boost, and as it increases the pressure, trying to push that blood down into the ventricles, that is going to cause a more increased flow, and since the space is narrowed, turbulence is going to chaos is going to occur, and that will give us a mid-diastolic murmur. That is to be the mid-diastolic murmur of mitral stenosis and tricuspid stenosis. Then, besides that, we have the continuous murmurs. These ones are going to occur throughout the S1 and S2 there. And these ones is most commonly going to be due to efferent ductus arteriosus. But sometimes it can be extracardiac. For example, venous harms and pericardial rubs. Maybe like pregnant women, sometimes there is increased, the bedside are engorged and the blood flow is also increased in preparation for feeding of the infant and everything. We have some maneuvers that we do when we're trying to evaluate these heart murmurs, because sometimes you're going to hear a murmur within systole or a murmur within diastole, and you won't be able to tell that due to a mitral valve, is this due to a tricuspid, because they're going to sound so. For example, a pansystolic murmur, it can be mitral, it can be tricuspid, but you can't tell which one is where so easily. And sometimes we have to employ certain maneuvers. So the first maneuver we can try is the inspiration. So when someone inspires, the intrathoracic pressure reduces. When this intrathoracic pressure reduces, more blood is going to return to the right part of the heart. So if we have a pathology on the right side of the heart and we increase the flow there, we are going to have a turbulent flow of increased intensity, and this is going to produce even a higher and higher sound, as you can already tell. So when someone inspires, more blood is going to enter the right heart. But surprisingly, because of the capacitance of the pulmonary veins, they're able to a bit dilate more, they're able to expand, they're able to contain that pressure, and the pressure getting out and the blood usually getting back to the left heart is actually going to be reduced. Therefore, when we tell someone to inspire, only the pathologies on the right side will be accentuated, and this is what we call a Cavallo's sign. So Cavallo's sign help us to identify these right-sided heart murmurs. So you can think of tricuspid. Then we can think of things like valsalva. So when someone does valsalva or when someone is standing, it's going to reduce the preload to the heart. So the right heart, the blood coming back to the heart is going to reduce. Most of the murmurs are going to decrease because the blood flowing over the obstacles is also reduced. But surprisingly, during hypertrophic obstructive cardiomyopathy, because remember, during hypertrophic obstructive cardiomyopathy, the heart is asymmetrically enlarged at certain points. So if this is hypertrophy, is causing an obstruction in the outflow, most times it is high pressures that are going to relieve that obstruction. So during this maneuver, or during when we do a maneuver that reduces the preload, we are reducing the flow to the heart, and therefore the blood that was distending that obstruction away is going to reduce, and the obstruction due to the hypertrophy is going to cover the outflow. And because of this, that murmur will increase. So hypertrophic obstructive myopathy is going to always cause an increase in the murmur. when we have anything that reduces the preload. Then when we go to the squatting or the leg raise, and as you can see when you squat, you're increasing your total peripheral resistance, you're increasing the you're increasing the venous return, and you're increasing the preload. There's something with the passive leg raise. Someone lies on the back, you put the legs up, you're increasing the blood flowing back to the heart. And as this blood flows back to the heart, it is going to increase the blood. It's going to increase that flow. So what is going to happen is that when you have murmurs like aortic stenosis, mitral regurgitation, and ventricular septal defect are going to, since more blood is going to pass over these valves, those murmurs are going to be increasing, they're going to be accentuated. And the one for hypertrophic obstructive cardiomyopathy is going to reduce, because you see the high pressure is going to relieve that obstruction, and therefore we shall have a more streamlined flow of blood, so we won't have a murmur being produced. Then we have also the mitral valve prolapse, which is also seen to decrease as you increase the return to the heart. Then we have the hand group or the isometric exercises. This is where we exert force. The hands are exerting force on something. Maybe we are squeezing something. The muscles are in action, but they are not reducing anything. And this is going to increase the systemic vascular resistance, which means the blood in the aorta is going to have a higher pressure. So this higher pressure is going to accentuate murmurs that go backwards. So from the aorta going backwards, when you increase the pressure in the aorta, blood will, or the pressure in the left part of the heart is going to increase. So if we have like an aortic regurgitation, it is going to increase. And as you can see, if the ventricle is also pushing against a high systemic resistance, the pressure pushing through the mitral valve is going to be high. So if we have mitral regurgitation, that is also going to increase. Now, if you have also a VSD, a right to left VSD, and blood has been shunting from the right to the left, and you go or from the left to the right, I think it doesn't matter. But you increase the systemic resistance, the pressure in the left heart is going to increase further, and this is going to push back into the right heart. So this hand group or the isometric exercise or any maneuver that increases the systemic resistance is going to result in increased pressure in the left heart, increased pressure in the aorta. And if you have a mitral regurgitation, if you have a VSD and you have an aortic regurgitation, that murmur is going to be accentuated. Then we have some important notes talking about the crescendo, decrescendo, because these are things you may see in an exam. And you may wonder, how do I know why is it crescendo, decrescendo? Do I have to remember which specific valve is going to cause a crescendo, decrescendo? And to me, I think you don't have to. You just have to think about it and see. So when you have an outflow obstruction during systole, as the ventricles begin to contract, the pressure is going to be high. And because the pressure is high and the pressure is increasing, because the ventricles are pushing and pushing and pushing, that pressure is increasing. The sound of the murmur is going to go up and up and up. And that is what we shall call the crescendo. And towards the end, as the blood is emptying from the ventricle, that blood, the pressure is going to start going down. So we shall have a down slope of sound, which we call the decrescendo. And this is going to happen in things like aortic stenosis, pulmonary valve stenosis, because blood is finding it difficult to get out at high pressures, and then the pressures fall, so it is relieved. But pansystolic murmurs are going to be caused by a constant leak. Blood is flowing through the mitral, is flowing through the VSD, is flowing through a regurgitant tricuspid. As soon as the ventricles begin contracting, that blood is going to go back. And throughout the whole procedure, some blood is going to go through the aorta, some blood is going to continue on its right way, but it will continuously be trickling. And that is what's going to produce the pansystolic murmur. Then we have the mitral, which will always give us a blowing murmur. We have the VSD, which is going to be harsh. We have the aortic stenosis, which is harsh and also rasping. So a few of these you have to keep in mind, but I think I've covered most of the important mechanisms of how we get these heart murmurs. So further to understand these things, you may have to understand some other valvular pathologies and put the knowledge together so that you can come up with something concrete. But I think that's it. And I encourage you to leave a like and comment and subscribe to Made One Pager if you would like to have more such videos, if you like to see so much more of this, yes. Because I try to put up these charts which I always post on the socials, so you can always just go and download it there and have it for your own revision or to look at after. Thank you very much. My name is Benjamin. See you next time.